Hi everyone, we are now live with FCI Instagram in honor of Pride Month, featuring all the things that you may be curious and wanting to know about issues that pertain to LGBTQ community. Adding Dr. Ahmad, so I apologize.
And
Hi everyone, we are now live with FCI Instagram in honor of Pride Month, featuring all the things that you may be curious and wanting to know about issues that pertain to LGBTQ community. Adding Dr. Ahmad, so I apologize. It always takes longer than it should to get her to add. Oh, great! Hi.
Hi.
How are you?
Good.
Good. So, first of all, if anybody has questions, please just ask so that we can make sure that they get answered and addressed. We're going to start with a little bit of kind of Q&A of what I would call things that are commonly asked when patients see us. But please ask away so we can make sure that those of you tuning in, thank you for being here live. It is worth your while. So to start out, Dr. Ahmad, please tell us a little bit about yourself.
So my name is Asma Ahmad. I am a physician at Fertility Centers of Illinois, and I've been there for now, I think about 2.5 years. And, originally from Illinois, I have some patients for which this would be relevant. So it's really amazing that we're doing this right now.
Great, awesome. My name is Jenny Hirshfeld. I'm one of the other physicians at FCI. We're really excited to be here. So some things that people ask about all the time, Asma, is when they're choosing whether it's sperm donor or egg donor, whether there's an advantage to being anonymous or known. And perhaps we can start with sperm donor. If you want to sort of share your experience of things that sometimes people aren't even thinking about when they're making that decision.
Yeah. And, for every individual or couple, this may be different and their thought process around that may be different. But I'll start with just like logistics, right? So logistically, I feel that it's easier to use an anonymous donor. And the reason is a lot of the stuff has already been done around making sure, like their STD testing is completed, genetic screening has been completed. We already have typically their sperm already stored in a bank, sometimes multiple vials of it. So, what happens is like, let's say like you're looking for a sperm donor, you may go to the website of or create accounts with different sperm banks and then start looking through the available donors. And because all that stuff has already been done, once you find somebody that you think that you might be interested in using, it's just a lot easier because you don't have to wait for that stuff to be completed. Once you're ready for treatment, once your doctor says, hey, it's okay, let's just get the sperm shipped over, you do that and you're set. With a known donor, it doesn't work that way typically, especially if they've never donated before. One is that you want to make sure that the doctor screens them, gets their past medical history, family history, does a genetic screening, STD testing, etc. And if they do well with that, then they may be accepted as a donor. But again, that takes multiple steps. But for some people, they may want to use a known donor for specific reasons. Sometimes because the genetic material comes from one side of the family and they would like to do that, or it's a friend or somebody that they know. But again, like, and then kind of going back to you on this is that there's other things to consider when you're using a known donor too, right? That sometimes people haven't thought about.
Yeah, yes, no question. I mean, I think there is a perception that it'd be easier to use someone you know, which you outline logistically, ironically, it's more complicated. And then there's the concern, whether it's egg or sperm donation, that the relationship you have with the individual is first and foremost. And theoretically, sometimes that can be impacted in this context.
Mm-hmm.
And so really sorting those things out in that decision making, even before proceeding forward with utilizing whether it's sperm donor or egg donor, for building your family, one of the things that people do or couples do or individuals are doing are utilizing meeting with one of our psychologists to walk through some of that decision making. So if it's utilization of a sperm donor, thinking about the true pros and cons of known versus anonymous. In terms of for utilization of a egg donor, so clearly if we have same-sex male couples who are identifying an egg donor and then ultimately a gestational carrier as well. Some of the things that no question are important to consider are some of the costs that go into this.
Yeah.
And so both egg and gestational carrier can be pretty costly and quite costly. So when you're identifying an egg donor, if there's a family member or a sibling, what I would say is really the most important is to make sure ahead of time that their ovarian reserve is really optimal. They are in that optimal ideal mid-20 to upper 20 age. To create all the procedural costs and everything else, we want to make sure it's really a good fit. No question, I think some of the other things when you're choosing an egg donor and a sperm donor, the sperm donor, it seems a little more streamlined within the different sperm banks, although I would say that most commonly we work with Seattle Sperm Bank, we work with California Cryo Bank, we work with Fairfax. It's really important to use a reputable sperm bank.
Yeah, and that's the thing is like check, like if you've established care with the clinic, to double check with them what sperm and like sperm donor banks or egg donor banks and even surrogacy agencies and gestational carrier agencies that they work with, because sometimes people have already chosen someone, you know, whether they found them off, you know, through an agency or through a website and sometimes through social media, but then when they come to the clinic with that as a potential gestational carrier or donor, it turns out that they wouldn't be the ideal candidate. So yeah, I think it's really important to
yes. And I think in this realm of egg donation, some of the things that you want to be wary of is, for instance, we have an egg donor program within our own facility. We do the screening, whether it's genetic screening, medical screening, psychological screening, before that person becomes on our database. That's not always the case. And so time, cost, everything's incurred. You want to really know, okay, what has this person undergone before I'm choosing them? What has yet to be done? So I think those are the important questions, making sure you're aligning with places that your clinic and your physician works closely with. All of that's incredibly important. I think also when we think about the time frame, so when you're identifying an egg donor and a sperm donor, depending on sort of the desires of the couple to create a family, that it is no question it can be a very big decision, but it is not as difficult. There seems to be more prevalence clearly of sperm donors and egg donors than there is of gestational carriers. So again, in this context of trying to think all at one time, that you appreciate the gestational carrier can take somewhere 3 to 6 months to identify. I would say that as we're thinking about all these different sort of unique ways that family creation is occurring in LGBTQ families, I think one question that I get often from some of my same-sex female patients is this idea of reciprocal IVF. So Asma, if you wouldn't mind describing, like, what does that even mean? What are some of the pros that you would perceive?
Yeah, it's one of my favorite things to do, actually. So reciprocal, so when you think, like, to just take a step back and think about pregnancy and how it occurs, you know, you need an egg, you need sperm, and then once an embryo has been created, that grows inside the uterus. So in a same-sex couple, you have the option of getting eggs from either individual, and either individual could carry because both of them have the eggs in uterus. Now, typically, unless like there's something going on with diminished ovarian reserve, etc. And so one thing is they choose the sperm donor, and then what they do is they decide whose eggs and whose uterus they want to use. And sometimes that both comes from the same individual, and sometimes one partner will contribute her eggs and the other partner will carry the pregnancy. And that's what we call reciprocal IVF, because IVF is involved, the egg retrieval, embryology lab, all that is involved. But, you know, both individuals are participating in the pregnancy in different ways. And I think it's a beautiful thing. It's amazing. Now, there's this other thing that is available now as well. It's called the InvaCell device. And what it also does is it allows both individuals to carry the pregnancy. So not just contributing the egg from one partner and the other partner carrying in her uterus, but both individuals can actually carry the pregnancy for different parts of the pregnancy. So one could have the InvaCell device, which is placed inside the vagina. So the eggs and the sperm are placed together inside the vagina, and the individual carries it inside her vagina for, 3 to 5 days, depending on what protocol they use. And after that, and that's like when the embryos are, when the eggs are being fertilized, so at the initial stages of the embryo development. And after that, the device is removed, the embryos are removed, and then could be placed into the other partner's uterus. So there are different ways to do it. But I think it's a great way for the partners to, both be contributing to the same pregnancy.
And some of the other things in terms of InvaCell exactly is we think of the cost piece. So when a traditional IVF, women undergo injection medications for a week and a half. a retrieval is done, where the eggs are retrieved, egg and sperm are combined. All of this is occurring in an embryology lab. Embryos are grown typically to day 5 and then placed into a uterine cavity. InvoCell sort of takes a piece of it outside the embryology lab, therefore diminishing the costs. Because the cost is less because there's less involvement in the embryology lab. So at day that the eggs are retrieved, egg and sperm are combined in this thing that almost looks like a thimble. That then it's placed vaginally. 5 days later, when it's taken out, the embryo is identified. In INVO or IVF or in general, the other question I get a lot, which is a big decision, is this idea of, cost aside, time, everything else. Everybody wants us to work the best the first time. And so what would your thoughts be about how many embryos to place? What are ways that people can think about that so we make decisions that are not just focusing on the pregnancy test, but obviously the health of the child?
Yeah, I mean, what I say counsel my patients on is, ideally, the best clinical outcomes result from singleton pregnancies. So one baby at a time is best for mom and for baby, because when people do have multiple gestation pregnancies or twins or triplets, in some cases things work out great, but when they don't, they can be, pretty complicated situations where, there may be a early miscarriage, or the babies might be delivered at a time where they're considered peri-viable, where they're barely at that point where they may survive, and if they do, they may have long-term health complications. So when we come to the conversation about how many embryos to transfer, it depends on the age, it depends on the prognosis, but the goal is to have one baby at a time. So let's say somebody's doing genetic testing, right? With the genetic testing, typically, this may vary per lab, clinic, etc. But like you may say that for a genetically tested embryo, you have like about a 60 to 70% chance of success. That's great. But putting 2 in could result in you having twins, and sometimes because there's a chance that one of them could split, even triplets, and that can result in a complicated pregnancy. But in general, like if someone's young, where more of our eggs are genetically normal, we may just opt to do 1 embryo at a time, or if it's genetically tested. Ultimately the goal being 1 baby at a time.
Yeah, absolutely. And so kind of just to highlight the idea of embryo testing or genetic testing is this notion that when embryos are created on day 5, a biopsy of the embryo can be obtained so we can learn the chromosomes of that embryo, the genetics of that embryo, as a way to, I would say, really optimize success, because you're getting rid of the noise. You're minimizing the embryos that would be chromosomally abnormal. In theory, it should work better for every single patient, regardless of your age. Yeah. But in practicality, that's really not the case. And there have been a series of studies that shown, especially in egg donation, we do not see improved pregnancy outcome, meaning you tested, you didn't test, the pregnancy success has been the same as sort of live birth. The one piece I would say sometimes to consider is a couple's utilizing gestational carrier. Some of the peace of mind of doing that genetic testing is, when we look at studies, we look at large groups of people and we look at averages, of course. That's how studies are always done. That doesn't mean that every single person in that study had that similar outcome. And so studies look at large groups to answer a question, and I think we are trying to create more personalized medicine. And so when someone is utilizing a gestational carrier, that is the one case that I think you can actually suggest there can be an advantage of embryo testing, given, again, all those things that have gone in before you even started the transfer, identifying the gestational carrier, taking on that cost, that emotional investment, that sometimes, even if it's not statistically significant, it's clinically significant to decrease miscarriage rate by identifying that better embryo. But absolutely, I think also to reinforce that our goal is a healthy child, which optimally is achieved 1 at a time. So I think some of that is just that awareness that 2 is not necessarily better. Couples that would use a gestational carrier, such as same-sex male couples, should also be mindful of gestational carriers. There's a contract that is created, and often in that contract, you are delineating exactly how many embryos you would place.
Yeah.
And so I think that gets to sort of the other picture, that sometimes the appreciation when patients with an LGBTQ are attempting to create their families is, again, some of the logistics. So identify the sperm donor, the egg donor, the gestational carrier, but also appreciate some of the other components. So even if you're working with an agency, you still want your own legal representation.
Yeah.
There are standardized contracts, but this is really, really important. And the gestational carrier would have separate, and the egg donor would have separate. That when you are thinking about things in that context, some of the things that you're deciding together with, for instance, the gestational carrier, is how many embryos you feel comfortable placing. If later on in pregnancy something is revealed that is suboptimal to the health of a child, how both the intended parents and the gestational carrier feel most comfortable to handle that. So those are some of the things.
Those are really
important. The more you think through. Mm-hmm. And the idea that every state is different. So sometimes there's an advantage to being in a place like Illinois where the laws are more favorable. And so really educating yourself is part of our process.
Do any of your couples ever ask if they can, and you've probably come across this so that our viewers know, to be able to use the same individual as an egg donor and gestational carrier? Has that ever come up with anybody?
It has more in international. So yeah. So please share what you would say in terms of traditional surrogacy.
I mean, in terms of traditional surrogacy, yeah, they would be one and the same. I haven't had anybody ask that, but again, like when I talk to individuals who are from different countries, that's something that's done more commonly. Yeah,
I think in the U.S. it's something that there are concerns about some of the theoretical ethical implications of both the woman providing both the genetic connection and carrying the pregnancy. Mm-hmm. And so it's usually something that is not done. Yeah. But it is something potentially that couples would ask. In terms of for you, so when you see patients that are asking about sort of the process and logistics, are there other sort of overviews that you find helpful to give in terms of timelines? Or
yeah, I mean, so it depends on what services that they're trying to utilize. So just like you mentioned, I think the gestational carrier portion takes the longest. Or for instance, if they haven't chosen an egg donor yet and they would like to do a fresh cycle, depending on how they choose that egg donor, it may also take a couple of months, right? So let's say it's somebody who's never donated before, has either gone to an egg bank, shown that she's interested in donating, but hasn't done any of her testing or anything yet, and just like filled out her past medical history, etc. So let's say they choose her, then she would have to do additional testing to make sure that she would qualify as a good donor, and that can lead to a couple more months. That's why in some cases it is, and I guess in all cases important to discuss what their timeline and expectations are so that you can better guide them on what would make their the whole process easier for them, so they could reach their goals. In the case of frozen eggs, it tends to be a little bit easier, again, logistically, because everything has already been completed. The eggs have already been frozen. So when they choose someone from there and everything's lined up from their clinic, they can also have those eggs shipped over pretty quickly to continue with their treatment.
And just to highlight, what is the difference, if you don't mind, between our audience to share between using frozen eggs or doing like a live egg donor?
So one thing is the logistics, right? The frozen have already been honestly frozen and they're already there. You already know what you're getting. Granted, you have to keep in mind that not every frozen egg will thaw and survive, but you pretty much know what you're getting. In terms of the fresh one, the one benefit that I see to that is, especially if you choose an egg donor with a very good ovarian reserve, which typically you will, someone in their 20s, those eggs may be for you to utilize, like all of them. So let's say she gets 20 eggs, those 20 eggs will be yours. Whereas when you typically purchase or get frozen eggs, they're usually available in like a lot of 6 eggs or 7 eggs or 8 eggs. So the number may be a little bit lower. So somebody who may be trying to build a larger family in the future, granted you're not going to be transferring all the embryos right away, may want to use a fresh donor who has a good ovarian reserve.
Yeah, I think some of the other piece, the egg bank is a national egg bank, and there are various egg banks that we work with that there's a greater opportunity to have a more diverse group of women who have volunteered to be a participant. So that's some of the advantages potentially with egg bank, because less eggs are obtained versus a live donor. Sometimes to adjust for that is the idea of purchasing more than one lot. But
yeah, you could do that as well.
In terms and to kind of pivot, and so please, all of you that are listening, if there are questions that we've just done too fast or things, please ask us. Yeah. But to kind of pivot to patients in the trans community, I think some things that we as a field maybe have not done a great enough job doing is describing ways that fertility preservation can occur. So as someone is in the process of transitioning, before potentially even undergoing hormone medications, some of the advantages, the opportunity then to either freeze sperm if appropriate or to freeze eggs if appropriate. Clearly to freeze sperm has an ease, right? If you freeze sperm, it really is establishing with the clinic a day that a sperm sample could be dropped off. The freezing is relatively straightforward.
Yeah.
There are some costs associated with it. It can be done more than once to accumulate a greater group, so that before hormone medications are obtained and created, that somebody would not need to stop hormone medications to then do a sperm freeze, or if surgery is going to be done ultimately as someone is transitioning to female, that those things can be done ahead of time, and just be aware of that. Same occurs, of course, with freezing of eggs. It's just more involved in terms of the logistic piece. Could you just walk through a little bit, Asma, for someone who is thinking of before they're transitioning and is considering hormone therapy before that starts, someone who was born female who would want to freeze genetic tissue to use in the future for the potential, whether it is before hormone medications or surgical treatments? What would the process look like? What are the medicines? What's the timeline?
So someone transitioning from female to male, like preserving before transitioning?
Yeah, position. Yeah.
Yeah, I mean, there's a couple ways to do it. One way would be to do like IVF cycle and freeze your eggs. So, similar to other IVF cycles, you would take medications. The stimulation part of that would last about like 8 to 14 days on average. Then that would be followed by an egg retrieval. Egg retrievals are pretty quick. They're usually about like 15 to 30 minutes long. And then that day that you have your eggs retrieved, probably know the total number of eggs. And the next day you may know like the maturity of the eggs that were retrieved. And from there you would decide if that's a number that you feel comfortable with. The other option could be cryopreservation of tissue. So you could have a surgery completed, like a laparoscopic surgery, have part of an ovary or a ovary, depending on what you decide with your doctor, frozen to utilize later. Now, for the most part, the patients that I know of who have gone through this have done egg freezing beforehand. Now, when it comes to males, I think, this is a really sensitive topic for me because I personally knew somebody who had transitioned and no one had discussed this before with her. And so she had talked to me about it and said, I really wish someone told me that I could have frozen my sperm before I had transitioned. So again, just like you said, the sperm piece can be logistically a lot easier. And even if you're paying out of pocket for this, less expensive. Yeah. But it's really important to have that discussion.
In terms of considering things like egg freezing, another topic, whether it is in the context of transition or any other indication someone's considering egg freezing, questions that will often come up is, what if I decide I never want to have a genetically connected child? What then? What could I do with those eggs?
So you never want to have a genetically connected, I guess.
So somebody has frozen eggs, but now decides they don't want to use them. I feel like you get this question a lot of, what are the options, how to use those eggs?
Well, one thing is you could donate them, right?
Yeah, donate them and discard them. I think it's not you can give back to the greater good in the sense of becoming an egg donor or something of that nature. I think there are ways that it's, I think it's a big decision to make, no question. You don't have to obligate yourself to have to use them just by freezing. It just gives you options.
Yeah, it gives you options. And I think that part is important because you may be thinking something right now, but 10 years, 15 years down the road, you may want to have alternative options. So that just kind of leaves the door open if you do decide to do that in the future.
Yeah, absolutely. I would think that some other topics are things that people often ask, because no question this gets to be a lot. Like an overview. So if somebody is seeing fertility physician for the first time, and for instance, let's say that you are interested in utilization of sperm for IUI, and so it's usually an initial visit. Within that initial visit, typically some testing is done. And so, for instance, if it's a same-sex female couple, that couple decides if only one of them desires to be pregnant, both to be the egg source and the uterine source. They go through some testing. They walk through, identify a sperm donor, and that process, depending on what is done, can be relatively fast. Same-sex male couples, again, it is both identifying the egg source and the uterine source, or an egg donor and a gestational carrier. There are some logistic pieces that occur in terms of testing is done of the sperm, FDA-based testing. And so I think it's helpful to appreciate that it is an initial visit and then a series almost like checklist items, but very doable. This is not something that is not feasible. This is not something that is, months and months in the making necessarily. So I think sometimes it's helpful just to have that piece of it. I mean, I think we really try to pride ourselves. We have an entire group that is focused on helping to identify egg donors and gestational carriers so that this can be as seamless as possible. I just wanted to touch upon the cost piece.
Yeah.
I don't know if you have average number costs that you typically would give to someone if they're considering sperm donation, for instance.
I tell them that they should be prepared, depending on how many vials they buy, et cetera. It can cost a few grand. In terms of egg donors, depending on, again, like if they're doing a fresh cycle with an egg donor or frozen eggs, that may be, again, depending on the bank. There's a range. I would say like 4,000 or 5,000 to, it could be like 20,000, depending on how many cycles, if you do a fresh cycle and she's taking a lot of medication, et cetera. Including genetic testing, plus or minus that. Gestational care, I think, is where the biggest cost is, and for that, I say it can be like upwards of 100,000, depending on the fees around it. I think that's usually with an anonymous gestational carrier. Now, if it's a known gestational carrier, that may reduce the cost for you.
Yeah, exactly. I think it's helpful to have some ranges. Even sometimes I think people are surprised about how expensive a sperm donor can be. I just would say that within the Chicagoland area, if anybody listening lives within Illinois or Wisconsin or Indiana, FCI's partners with a nonprofit called, we just changed our names, so we have to look up again, Chicago Coalition for Family Building. It used to be called the Life Foundation, now Chicago Coalition for Family Building. Something I'm personally very passionate about. I'm the vice president of this organization. Just want to make people aware that we have monies to give. And so monies to give cash grants, we do top them at 10,000. And so as she just highlighted of cost, it is not going to be the solution. It is going to be a contributor. But it is something, and I think it is organized by physicians as a way of saying, here are ways that we can hopefully help people reach their goals. Separately, there are donated IVF cycles. There's often donated legal services. The legal services can be an additional piece. So please look at the Chicago Coalition for Family Building on Instagram. Apply. Grants are live now. And so it's also a great way of being able to get things covered. I think often state to state, there sometimes can be some differences, potentially for certain components to be covered, particularly for some of our same-sex female patients, depending. And so I think all of that information is something you would typically get within our first visit or so. So, information is power, what to understand with testing, successes, and that the idea of cost. You had identified sort of if we screen embryos that we have about that 60 to 70% success, which I would agree holds true if someone is utilizing an egg donor. What would you quote success for women who are utilizing IUI therapy? So same-sex female couples who are utilizing IUI, how would you quote them success?
I think it depends on their age too. You have to take that into consideration. But I would say, let's say she's someone in her, early 20s, then I would say like 25 to 30% per cycle.
Yeah, so we're recreating peak mother nature. So when you're young and you're considering IUI, it's still a very good option. So the limiter of IUI is it still can be costly. So something like that grant can be helpful. Finding out if you have flexible spending, depending on the state you live, there's different sort of systems in place to help for coverage.
Yeah, I think that's important. Like, I think that information. So you said Chicago Family Building is the new name for the previous foundation. Okay. There's also like websites online. I mean, when you meet with your doctor, they probably have a list of resources that they can give to you.
Yes.
But I do that as well. Like I ask the individuals if they have coverage or not, because we're in Illinois, so it's mandated. A lot of couples and individuals have it. But there are like some websites online that have a list of different grants that are available. So when they meet with their doctor, they can ask them that.
Absolutely, and different funding sources. Especially in sort of the craziness of COVID, that theoretically some insurances could change or someone's job employment can change.
Yeah.
So we're almost done, but I was going to ask you to share sort of your insights, because patients now appropriately so are more asking about how does COVID-19 impact utilization of egg donor or gestational carrier?
We've with the patients that I've had, we've been able to move forward. I think things have just, life in general has changed with COVID for everyone. different businesses, etc. And the same thing is true with medicine. The differences that you'll see in our clinic and probably many other fertility clinics in the US is that a lot of the consultations are being done via telemedicine. So, Zoom consults, etc. And then the clinics are open for treatment. So you are able to come in to do your blood tests, your ultrasounds, etc. But, previously you were able to come in with your partner. If you had a baby already and you needed to bring, you didn't have childcare, you could bring your child in. But now it's you have to come by yourself or alone and wear a mask. And I think that's like what's being done everywhere. But we have been able to reopen all services that we had previously.
Yeah, we open all services. We will screen if someone's utilizing IUI. You will be screened at the beginning of your cycle. If we want to know asymptomatic women who could have COVID.
Yeah.
That we don't clearly want to achieve pregnancy at that time. We also want to make sure we make our office as safe as possible by screening those doing treatment. Same with an egg donor would be screened. Same with a gestational carrier. Same with reciprocal IVF. So that would be a component of the care.
Yeah. Screening does take place. That's true.
We are kind of at the half-hour mark. So thank you everybody who has participated. I'm going to figure out now how to record this, so that's the next step of the day. But please, Dr. Ahmad, what if there are any sort of closing thoughts that you think are helpful just to share?
Yeah, I mean, the thing is, physicians are available to answer all questions. I mean, you guys have our accounts on here too. So if you have any questions, you could always send us a message through Instagram. We'd be happy to answer. But I think it's really good that if you are thinking about doing treatment, that you speak to your physician about it so that you can figure out, what steps you need to take, what options you have available, because obviously, like, everyone's in a different situation right now, but sometimes delaying things can also affect your results when you do ultimately do treatment. So it's good to know what your options are and how that may change over time.
Yeah, absolutely. Yeah, I think, again, that sometimes it's just obtaining information and knowing at a first visit that you get an idea of the roadmap.
Yeah, that's true.
Awesome. Well, thank you. Thank you so much. Thank you to everyone that listened. Yes, that is kind of it. All right, everyone, be healthy and well. Continue to wear your masks. Wash our hands.
All right, take care, guys.
Okay, bye.